The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
Healthcare is both essential and a fiscal behemoth that at almost $70 billion per year eats up close to 40% of Ontario's budget. Do the extraordinary times of this pandemic call for extraordinary measures? Tonight, for the full hour, we'll explore what could help fortify the system, including whether there's a role for more private delivery of healthcare in Canada's public regime. It's Thursday, October 14th, and that's next on The Agenda. Ontario's healthcare system has been battered by COVID-19. Medical staff have been pushed to their limits for sure. And there's a massive backlog of diagnostic and surgical procedures built up as a result of shutdowns during the pandemic that some worry will never get sorted out. It's been floated before, even as recently as in the federal election campaign. Should provinces consider looking to the private sector for help tackling the healthcare crunch? Well, let's get into that with, in London, UK, Alistair Maguire. He's the head of the Department of Health Policy at the London School of Economics. In our nation's capital, Colleen Flood, professor at the University of Ottawa and a university research chair in health law and policy. And in the annexed neighbourhood of the provincial capital, Sarah Allen, assistant professor at the University of Toronto's Dalla Lana School of Public Health and the Institute of Health Policy, Management and Evaluation. And we're grateful to have all three of you with us on TVO tonight. I want to start by just outlining the nature of the problem we're facing here. And these are numbers from Ontario's Financial Accountability Officer. That is a neutral office, nonpartisan, responsible to reporting to the legislature. So these numbers are, as they say, not torqued. These are numbers from March of this year, and it shows the estimated cumulative backlog of elective surgeries thanks to COVID-19. And for those listening on podcast, I'll just describe this. If you go back to March of 2020, when the pandemic began, we had fewer than 50,000 cases in the surgical backlog. But then as the months proceed, suddenly we're up to 250,000 by March of 2021. And the forecast for the future is to be well beyond 419,000 as we go forward. So this is an enormous backlog that, as we suggested in the intro, some are wondering if we're ever going to get out of. Question one, Colleen Flood, to you first. Is our healthcare system, as it's currently constituted, remotely capable of dealing with that backlog in a timely fashion?
Well, I think so. We will have a challenge, no doubt, to respond to it. But you know, whatever our problem is, we have X number of doctors and X number of nurses. That's not easily corrected in a really short time frame. So it's going to come down to adroit management of this, and I'm hopeful that with the rise of virtual care as well, that this will help. Now, I'm not saying it's not going to be a big challenge. Of course it is.
All right, I'm going to repeat the question for Sarah because, again, the key words here are, can we get through this backlog? People waiting for elective surgeries, they're waiting for diagnostic tests for cancer, that kind of thing. Can we get through that in a timely fashion?
I don't think it's going to be an easy feat. And what I'm hopeful is that this pandemic may provide that shock that we've all faced. That's actually a window of opportunity for major change. And we've known for decades that we have a major problem with wait times in Canada, and we haven't been able to address this. Now that the problem is bigger, it's more pressing. We saw the numbers. So I'm hopeful that we can kickstart major reform that will actually address this longstanding problem, and COVID may provide that opportunity.
Well, one of the things we want to discuss, and the reason that Alistair is on the program tonight, is that Canada is supposedly a single-tier healthcare system, meaning people of better means are not able to buy their way to the front of the queue. In the United Kingdom, they have a somewhat different system. And Alistair, I wonder if you could help us understand how your system works there in a way that might help alleviate the backlog if you had it over there, the likes of which we have here?
Well, there's some similarities. For example, I think there's very good reasons why we wouldn't rely on public health insurance, for example, fully. I think that any healthcare system is best funded primarily by public finance, through public finance. The problem with public finance is, of course, that you've got budget constraints, and you face budget constraints, which means normally for publicly financed systems, we don't really have the capacity to easily adapt to shocks like COVID. So we have capacity constraints. We even have capacity constraints, waiting times for elective surgery, for example, without COVID happening because of these budget constraints. But in the UK, we also have a complementary 13% of the population holding private health insurance rather, and that takes some of the pressure off the public sector.
Let me just follow up on that, because I want to make sure our viewers understand that. The NHS, the National Health Service in the UK, basically 88% of all the procedures done go through the publicly funded system. And as you just indicated, you got about 12% that use a parallel private system. What is the effect that having that 12% in the parallel private system on the public system?
So it's about 88% of expenditure through the NHS and 12% expenditure through the private sector. So it's not exactly the volume, it's the expenditure. But the question still stands. The public sector is facing widespread constraints. They have constrained theatre times, for example. And one of the ideas is that the private sector alleviates those pressures and therefore alleviates the pressures on the public sector NHS waiting times. Very difficult to prove that. It's difficult to prove it for a couple of reasons, but the main reason is if you have a private sector, it may alleviate some of the public sector constraints, but also demand for healthcare grows anyway. So you get a growth in healthcare because of the public sector moving into the private sector, but you also have alleviation of the public sector itself. So waiting times in the public sector may be lower than they would have been otherwise, but it's really difficult to prove that.
All right, let's get some feedback then from our Canadian guest. Colleen Flood, is there any evidence that you know of whereby if we introduced that type of model into Canada, whereby there were a private option and a parallel system to Medicare, that it might take some of the pressure off Medicare and make things better for both systems?
So recently we had a big court case that evaluated this question. 880 pages of analysis by Justice Stevens looking at expert witness testimony about it, and concluded that there wasn't any such evidence. So I think we've had a good thrashing of this again. The problem is, as I mentioned in my opening comment, is that we only have X number of doctors and X number of nurses, and they will only, already now we are feeling shortages in the public sector. So, we know that if we create a parallel private tier where the work is probably easier and higher paid, and perhaps then you can stay in downtown Toronto, downtown Vancouver, Montreal, that we will exacerbate, in my view, our existing problems. But I completely agree with Sarah that, that in and of itself is no reason to rest on our laurels. And, what happens is we sort of fall into these old, tired debates about public and private. Those of us who support a public healthcare system are constantly sort of fighting this battle instead of rolling up our sleeves and figuring out how the hell to fix wait times for everyone going forward. And there are possible solutions out there, and we really need to grab hold of them and beat folks around the ears at the political level to make it happen.
Okay, let me go over to Sarah then and get her take on whether or not you believe the British-style offering of a second tier is an option for Canada that might help alleviate the backlogs.
Well, I agree with the previous speakers that there is no evidence, no strong evidence that a parallel private option would alleviate these wait times. And in fact, the detailed studies of the UK showed that wait times were brought down through a mix of, massive increase in funding, public funding, setting of really aggressive targets, so setting limits for wait times, similar to what Quebec has done recently to try and, address the problem within the public system. And no credit really was given in the UK to the private parallel tier when they were successful in reducing wait times. So I think there are lessons that we can draw from many countries, but that doesn't seem to be one for many reasons. And I'm hoping we'll get into some of them that why it might not work in Canada either.
Well, let me just check with Colleen. Is it the Brian Day case? Is that the one you were just referring to, the court case?
Yeah, Brian, well, the applicant is Canby Surgical Services, which is the private clinic, and Dr. Day is the sort of main proprietor.
Okay. Well, we just happen to have a witness for the defendant in that case, the Brian Day decision in British Columbia. So, Alistair, I wonder if you could just give us a sense about what that case was about and what you testified to in that case.
So I wasn't a witness for the defendant. You're actually an expert for the court, so it's independent evidence, although it was Canby Surgery who called me to be an expert. But that aside, essentially it was a case about elective surgery, and the idea was that in the current setup, all Canadian provinces actually are meant to, if you're a medic or a healthcare provider and you contract with the public funder, you're only meant to take publicly funded patients. That leads to constraints, obviously, because the budgets are constrained. And because the budgets are constrained and the theatre times are constrained, you therefore have wait lists. You have to ration care somehow, either through prices or wait lists. If you only have a public sector, you do it through the wait list. The Canby Surgery said that if you had a private sector which went in parallel to the public sector, that would alleviate some of the wait times for individuals in the public sector, and that would then allow them to provide good health, to the Canadian population. Now, as I said, and as the others have said, there's no empirical evidence, but that's because the empirical evidence about the alleviation of wait times is difficult to come about, because not only does the public sector necessarily get alleviated if the wait times go down and you don't have any capacity build in the public sector, but there's also a growth in demand for healthcare generally because there's capacity to take it. So two things are happening. Wait lists may go down, but overall demand goes up, in which case the wait lists may not change at all in the public sector because you're alleviating it, but you're operating with the same number of theatres. Now, there is another thing that Colleen said, which I think is important. One of the big problems is it's the same staff operating in both sides. So, for example, when the Blair government was in power in the UK, they said that the staff could operate, public staff could operate in the private sector, but only if they had already provided 4 hours overtime to the public sector first. So it's very important to regulate how staff move across two sectors if you have two sectors. The last thing I'd say is that, not directly relevant to this case, but to the NHS just now in trying to respond to COVID, the NHS is actually purchasing capacity off the private sector to try to get its wait times down. And that's exactly what happened in 2008 to 2016 that Sarah talked about as well, where the wait times were coming down. They were coming down partly because the NHS had a contract with private providers.
Okay, let me pursue that with Sarah. Do you think, Sarah, we could make the same kind of arrangement here, whereby if doctors and nurses or whatever wanted to work in this parallel private, for-profit, perhaps better paying system, that could be allowed to happen, provided that medical practitioners commit to providing X number of hours to the public system, doing X number of procedures, and so on?
Yeah, well, it's a great question because it comes down to, what are the rules that we're currently operating under and what are the sort of objectives of Canadian health policy? And so we can look to the Canada Health Act, which in 1984 sort of lays out what is the framework that the health system is organized around. And one of the first statements you'll read is that the Canadian health policy is, aiming to ensure equity in access to care. So ensuring reasonable access to health services that are medically necessary on uniform terms and conditions. This was agreed upon across all governments. And so this idea of uniform conditions is pretty rare internationally. And we're actually the envy of many countries in terms of being able to achieve this, where if we do want to preserve this goal of uniformity in terms of access, then we couldn't then at the same time allow people to pay who, wealthier and those who have the means to pay for faster care at the, potentially at the expense of longer wait times in the public system. If we were to assume that there's no increase in capacity of physicians and nurses and beds in order to ensure that the capacity in the public system maintains. So we should really think collectively, if we want to maintain this goal of equity and uniformity of access, then this model wouldn't work. But if we want to overturn that legislation and really rethink and fundamentally blow up that system, then, all the regulations that Alistair started to list we would need to think through very carefully.
All right, I take your point.
That's
but now, sorry, Alistair, go ahead.
It's a great principle, but it's not happening as we speak, is it? Different provinces have different wait times, so they don't have the same uniformity of access as we speak. And that was prior to the COVID pandemic as well. It's worsened because of the pandemic. So it's a great principle, but the practicality is that you've got this postcode lottery in terms of elective surgery, at least as to where you live in Canada, as to whether or not you're getting access at the same rate.
Well, let me talk practicalities with Colleen Flood here for a second, because many years ago, of course you will remember, there was the Chouili case in Quebec. And the problem there was that the courts ruled that Mr. Chouili could seek medical treatment in a private, parallel, for-profit system if the public system was unable to deal with his issues in a timely fashion. What has been the impact, do you think, of that decision over these intervening years?
Well, I'd just actually like to go back and answer the question that was asked before about whether two-tier healthcare will make a difference. And just with respect to Alistair, I'm originally from New Zealand, and in both jurisdictions, before the advent of wait time guarantees, both countries had two-tier healthcare systems, and both struggled with enormously long wait times, far longer at that point in time than what Canada is working with. So the argument that ipso facto, therefore, if we slap in a parallel private healthcare system into Canada, it's just as likely to go very badly unless and until all these other measures that Alistair is discussing come to pass. And we really do have to be quite careful when we go jurisdiction shopping, like I like the French healthcare system, vive la France, let's bang it down here. It doesn't work like that. So, for example, in Canada, our doctors are paid on a fee-for-service basis mostly. They're not employees of the state in the same way that they are in the UK, and they haven't, had contracts imposed on them in the past. It would be politically really difficult to try to mimic the NHS-style system here. So we just have to be really cautious about this, hopping around.
Let me give Alistair a chance to respond to that, and then I am determined to come back to the Quebec case, the Chouili case. Go ahead, Alistair.
I agree. I don't think there's any easy solution, but I wouldn't go for a dominant ideology if it's not working. And I'm not defending the private sector at all here, but I just think that a predominantly public sector is kind of ruthless in the sense that it says if you don't need, you can't have immediately, or you have blocks on your access. So I think some alleviation of the public sector may be appropriate, but ultimately that's a political decision which would reflect the preferences of the Canadian population. And I'm certainly not going to tell any Canadians what to do.
All right, Sarah, maybe I can get you to come in here on the Schwele case, because what emerged from that case was the very strong signal sent by the court that if the Canadian Medicare system can't get people timely treatment to help their ailments, then it is legitimate for them to look to a different system to try to get timely treatment. What has been the impact of that decision over the years?
Well, it's a great question. At the time, there was this kind of shock. Like, is this going to increase the, options in the private sector? Are we going to have a sort of escalation in growth in the private health insurance market? And what we saw is that there wasn't much of a change. And on the sort of positive side, the government was really motivated to make some of these improvements that we're talking about. And I fully agree that we have constraints, we ration care based on wait lists, and that these wait lists are too long. But the government in Quebec decided to, use this, this court case to actually make improvements and set these benchmarks for what is a reasonable wait time for the priority procedures in the province. And in the combination of, ensuring these targets that were met, as well as the fact that physicians really didn't have the opportunity to work in both sectors. There's still other rules constraining physician behavior in Quebec, like in other provinces, that Alistair mentioned earlier around, you can't work in both the public system and the private system simultaneously. Those rules remained in place. And so we didn't see a huge escalation in private health insurance or in private parallel practice in that province. And so it's really interesting that it shows us that maybe we can address the problem of wait times with the currently publicly funded system, and prevent the kind of escalation of private insurance that many other governments across the world are trying to contain, and look to Canada to see what are the rules that we have in place that help us to maintain and protect the public system without allowing a growth of private health insurance that does tend to undermine equity goals. If we do have equity goals, then these might be worth maintaining. So it's a really interesting question. And in fact, in the Swedish government recently invited us to come and talk to them to say, how do we prevent the private health insurance from growing beyond, they're at about 2% of the population. They're worried that it's growing too high. How does Canada maintain this distinction? And wanted to learn about the context here because it was lauded as an exemplar.
I've still got a lot.
Really interesting to learn.
Forgive me, I still got a lot to get to here, but Colleen, I want a quick response from you, if I can, on the impact of the Schwele case and whether it had the both feared and/or other consequences that many wondered about.
It didn't result in the unbundling of or significant growth of a two-tier healthcare system in Quebec because of an adroit response by the Premier at the time to introduce wait time guarantees, as Sarah just said. But I think normatively it's had a big impact because, a bare majority of the Supreme Court indicated that, perhaps two-tier healthcare is some kind of an option. The devil's a lot in the detail. It was really a small challenge to the law that prohibits the purchase of private health insurance. Following on its heels, the much bigger challenge has been underway in the Canby case that Alistair is a witness in. And they're challenging all the rules. So the rules that stop doctors working in both public and private. It's a little unclear, but at first they were also challenging the rules that stop doctors billing above the amount that they are paid by the public system, the extra billing, and the private health insurance rules. So they're really going for the big kahuna, if you like, trying to knock over everything. And what the effect of that would be possibly chaos. And it would depend on the political stripe, probably, of the government in charge when, were that case to be successful. What would they do? Would they do as Quebec did and try to protect the public healthcare system? Or would they say, yeehaw, let's let her rip, and, we don't really like equality and equity and access anyway. We prefer the rich to have more. So it's a chaos kind of strategy.
I think I see Alistair trying to jump in on that. Alistair, did you want a word?
Well, I don't think it's all or nothing, right? You can have mediated extremes, and you can. I'm not saying it's not complex, but you're not going to have. You're absolutely right to pitch it as equity versus some form of enhanced choice and access. And it is true that the private health insurance would probably be taken up by the wealthier rather than the poorer in society for obvious reasons. But it could be progressive. If you've got a progressive tax system, you don't allow people to opt out of the tax system. And so the wealthy, if they wanted private health insurance, would pay twice. It could be a very progressive system. You would have to regulate the medics and the healthcare workers so that it's not costless. But I don't think it's an all or nothing choice. I think it's more complex than that. And what you've got just now is you're not facing up to any trade-offs between equity concerns, efficiency concerns, and choice of provider. And that's really what you want to face up to. If you really want equity just to win all the time, then that's fine. But you have to face the consequences, long waiting lists, maybe low pay for the providers, provider migration, that sort of stuff. But everything has some kind of cost.
Of course it does, but that's not what the case is about. The case isn't about, let's pick, some sort of idealized model of a two-tier healthcare system and what we have now. That's not what it's about. It's about knocking down all these laws. And as I said, it will depend very much on the political stripe of the government that is in power when that challenge, if it is ultimately successful, happens. And as Sarah said, what we saw in Quebec was that it didn't end up being so bad because of the way that the Quebec government at the time responded, which was basically to button down on the public healthcare system and introduce wait time guarantees. There is just no doubt in my mind that that would not happen right now if this challenge was successful in Alberta. The Shauli judgment was limited to the province of Quebec because it was a judgment that was successful only under the Quebec Charter of Rights and Freedoms. This challenge that is happening in BC is under the Canadian Charter of Rights and Freedoms. So if they're successful, this would apply across all provinces. And as I said, I think the outcome would be disastrous in many places. And there may be some provinces that respond. But I think what we need to do is really to fix the problem of wait times. And I think, as Sarah mentioned, the Canada Health Act, it is beyond time that the federal government started to demand of the provinces.
Well, let me jump in on that, if I can, because we're literally down to our last couple of minutes here. And Sarah, we've talked a lot about equal access. We've talked a lot about universality. One word, and I don't think it's in the Canada Health Act, one word we haven't talked about here is quality, and ensuring that quality is supreme. Does the Canada Health Act need to be changed in order to make a greater commitment to that, in your view, Sarah?
I think the federal government in Canada has huge capacity with its spending power to make a big difference in healthcare systems in Canada, whether it's through revising the Canada Health Act or simply through bilateral agreements where we're going to spend more as the federal government to support provincial health systems, but there's strings attached, and it involves quality, it involves monitoring, it involves wait time guarantees and other measures of quality. And I think there's a huge opportunity for federal government to work with the provinces to make those sort of agreements, whether it's through Canada Health Act or just using its spending power. I think that's a promising way out of this crisis.
Let me give our last word here to our friend from the UK and ask him, Alistair, you want to give us some advice on what path you think we should proceed on?
Well, I think, let me go back to what I first said. I think that public funding is the mainstay here. You have to have coverage for everybody. There can't be any exclusions, and you have to provide financial security for everyone with with the funding of healthcare through the public sector. That said, we have wait time guarantees in the NHS, 18 weeks from referral letter to elective surgery being undertaken, 4 weeks for cancer. Even before COVID, they were all smashed. They were all broken. We have 2/3 of our hospitals which are running towards financial deficit. And that all goes back to the overall budget cap that the public sector has. And as was set out by Sarah, that's a kind of trade-off that you're going to have to face. Either you accept some of these things, that you're going to have wait time guarantees, which will lengthen over time unless more money is put into the public sector, versus uphold the principle of equity. And they're not easy choices. I'm not saying anything's easy here. I'm not saying it's easy for Canadians like everybody else. It's just not easy.
That's for sure. I want to thank the three of you for coming on to TVO tonight and laying out the options for us and discussing them so intelligently. Alistair Maguire from the London School of Economics, Colleen Flood from the University of Ottawa, Sarah Allen from the University of Toronto. Great to have you all with us tonight. Thanks so much. Getting the right care to people in a timely fashion is not a new challenge in the northern reaches of this province. Presumably doing so under COVID-19 has been even tougher. With us now on that and what might help, in Marathon, Ontario, on the north shore of Lake Superior, Dr. Sarah Newbury, who's been on the front line of COVID-19 in her practice at Marathon Family Health Team. She's also Assistant Dean of Physician Workforce Strategy at NOSM, the Northern Ontario School of Medicine. And Dr. Newbury, we're delighted to welcome you back to the program. How are you doing?
Thanks so much, Steve, for that warm welcome. I'm delighted to be here as well. Thank you.
Maybe we should just start by having you give us a sense of what a typical day is for you. What comes through the door?
Oh, yeah, that's a great question. It depends to some extent on where the clinician is on any given day. But as rural generalist family physicians in the community of Marathon, we work in our primary care setting, in our emergency department, in our hospital inpatient ward, and of course, with COVID-19, we work in our assessment center as well. So what comes through the door depends to some extent on where we are, but certainly we see all kinds of presentations in primary care. We see the full gamut of presentations in our emergency department, from motor vehicle collisions to heart attacks to COVID-19 presentations. We manage many of those things in our inpatient ward at the hospital. And in our assessment center, we see everyone who has symptoms that may be consistent with COVID-19, and we do our assessments and swabs in that setting as family physicians and as part of the team.
Just by way of comparison, if you were a GP in Ottawa or in downtown Toronto, would you be seeing the same kind of stuff come through the door, or is what you're seeing different?
Well, I think in the office setting, Steve, absolutely. What we see in our primary care community practice is very similar to what family physicians see across the province. We do a lot of preventive care. We see people with chronic disease, so diabetes, hypertension, heart disease, cancer. All of the things that we see in our community-based clinic is what would be seen in most family practice settings across the province. What's different about rural settings actually is our involvement in the hospital, our presence in the emergency department and our inpatient unit, and certainly our interaction with the assessment center, which is really well integrated with our primary care setting.
Now, obviously, a lot of people in, say, Toronto or Ottawa, Mississauga, Hamilton, they may have a 15 to 30-minute drive to see their doctor. How far do people have to come to see you?
Well, it's interesting. Marathon is quite a densely populated small community, but we also serve two Indigenous communities, the communities of Bigtugong First Nation and Netmazagamick First Nation. And for them, they are driving between half an hour and 50 minutes to come to be seen here. We also go to those communities to provide satellite clinic services there to minimize the travel for people who live in those communities. But for anyone from the area who requires surgical services, who might have a higher risk obstetrical case who might need chemotherapy or radiation, they are having to travel to Thunder Bay, which is most days a 4-hour drive away.
Wow. All right. One of the things that we're trying to consider on our program tonight is, we got this report from the Financial Accountability Officer saying that we're, going to be upwards of 500,000 surgical and diagnostic backlog cases as a result of COVID-19, because the healthcare system, of course, has had to focus so much on that a lot of other things got left behind. And we're trying to figure out how to deal with that. And one of the ideas that's come forward is that perhaps privately owned healthcare clinics, still could be not-for-profit, could be introduced into the system as a way of trying to deal with that backlog. And I'd like to get your take on that and whether that is an option for your part of our province.
I think that's a really great question, Stephen. I think privately owned and publicly funded centers may have a role to play in terms of decreasing the surgical backlog in particular. I don't know that that will have a huge impact in rural communities across Northern Ontario, but certainly I think we do have a role to play in our rural communities to optimize way in which we receive patients back from our tertiary centers so that we can offload the work of our tertiary centers as much as we can so that all of the resources that we have to deal with the surgical backlog can be applied. It would be a rare rural community that would have a surgical facility, and so the impact directly in communities would be very limited.
In which case, is it the case that you just don't have the population there to support the potential work of a clinic like that?
Yeah, that's exactly right. So a community like Marathon, we have a population currently of about 3,500, and then the Indigenous communities that we serve and support here. We do run cataract surgery through our hospital, and we have a colonoscopy service, but those services are really only a couple of days a week and are actually well integrated into our hospital setting. The population base that would make a publicly funded, privately run facility make sense really doesn't exist in a community of our size or in this geography in particular.
Since you mentioned hospitals, let me follow up on that because, of course, over the last many years, we have seen, there have been a lot of hospital closures in rural areas across North America, remote areas as well. How much of this is happening across Northern Ontario?
It's a really good question, Steve. Certainly in the United States, there have been a significant number of rural hospital closures, roughly 125 in the last decade. We haven't seen rural hospital closures specifically in Northern Ontario, although we certainly have seen a decrease in some services. Obstetrical care services in particular have decreased in rural hospitals. And there has been an increase in the use of locum services to sustain emergency department coverage across the north. And that's certainly something that we've seen increasing over the last several years.
And for those of us who aren't great at Latin, locum services means what?
Right, thank you. A physician who fills in on a temporary basis. So historically, it might be that if I was going on a vacation for a couple of weeks, I would have a physician come and replace me for a couple of weeks to provide care to my patients in my absence. What we're seeing now across Northern Ontario is an increase in those fill-in physicians to cover emerge shifts, sometimes only 1 or 2 shifts at a time, simply because the local physician capacity to do all of the work that needs to be done in primary care, hospital inpatient work, emergency department, and the assessment centers, that local physician capacity is diminished in many of our communities, and we rely much more now on external physicians coming in to provide short-term coverage to keep services open.
Does that necessarily mean that the service is worse because they're not from the area and perhaps don't know the patients as well as a local person would?
So certainly what I think is that the physicians who are coming to provide that care are excellent clinicians. To your point, though, there are issues about the way in which we deliver care. Often in a place like Marathon, that means how do you navigate coordinating a transfer of a patient from our emergency department to Thunder Bay Regional? And certainly, if you've got some on-the-ground knowledge of the way that the system works, it's much easier to do that work fairly seamlessly. And certainly, having a knowledge of the population, having a knowledge of individual patients can help us to deliver high-quality care as well. And the other thing, Steve, that I would say is that when physician is coming to fill in for another physician, they're generally here to do the clinical work. They're not here to do the policy work and the system support work. That is part of what it takes to create a high quality healthcare system that is focused on creating access and delivering high quality care for the whole population. And so the more that we have clinicians in the community who've made a commitment to comprehensive care and continuity with that community, the more highly functioning that local healthcare system can be.
Sure, and I assume that's what NOSM, the Northern Ontario School of Medicine, is all about. If you're trained in the North, you're likely going to stay and practice in the North. Fair to say?
That's absolutely right. And two specific populations that have particular needs that are a focus of NOSM's education are the needs of Francophone citizens and the needs of the Indigenous population across the North. And NOSM has a particular focus on how we care for those populations. And I think our graduates come out of their training with a particular sensitivity to those populations and their specific needs.
Gotcha. All right, let me come full circle now and get back to that notion put forward by the Financial Accountability Officer that we have this multi-hundreds of thousands of backlogs now of non-elective surgical and diagnostic procedures, which I presume is manifesting itself in Northern Ontario as well. Have you got an idea or two you could share with us as to how you think that backlog could be tackled?
Well, I think from my standpoint, Steve, I think we have a huge opportunity to ensure that we are resourcing and creating capacity in our rural communities so that wherever surgical capacity exists in the system, we're able to use. When I think across northwestern Ontario, for example, we have excellent general surgeons in Sioux Lookout, in Kenora, in Dryden, in Fort Francis, and we need to be able to equip those communities, those hospitals and their teams to be able to do the kinds of procedures that they can do locally, because that means fewer patients having to travel to places like Thunder Bay. And then Thunder Bay can optimize the service that they're able to deliver. In small settings like Marathon, as I mentioned, we can do colonoscopies and cataract surgeries. And the more that we're able to do those kinds of procedures locally, the more we free up capacity in our tertiary center to be able to deliver the care that only they can provide. So from my standpoint, I think we need to look at how we resource and support and sustain our rural communities and our small rural hospitals so that they can participate as fully as they can in healthcare delivery for the whole of the system.
Does that simply mean more money?
It may mean more money. It may mean the way that we spend that money needs to be done a little bit differently. We've talked a lot recently about integrated care and the importance of integrating care across the system. In fact, just yesterday, there was a conversation led by Rick Glazier and Jim Rourke, who are two clinician researchers, to explore how we can better integrate care in local communities. And part of what that means is how do we better use the resources that we have, both fiscal resources and human resources, to optimize the care that we deliver here in service to patients and with patients at the center of that care. So how we utilize our paramedics in our communities, how we utilize clinic-based nursing staff to provide home and community care, how we coordinate services between hospitals and clinics so that we're really doing the most that we can with the resources that we have is a really tremendous opportunity for rural communities. And rural communities are small and they can be nimble. We can implement things quite quickly and quite seamlessly. What we need is the research capacity to understand what it is that we're doing from an evaluation standpoint and then be able to share that so that other rural communities can implement the things that are successful.
Dr. Newbury, we're always so grateful when you take our calls because we learn so much about how it works north of the French River, which, as we've heard, is often very different than south of the French. Thanks so much. Take good care, and we'll talk again soon, I hope.
My pleasure. Thanks again for the invitation.
We're about to introduce you to a man named Walter Schroeder. Business has been good for Walter. He made a lot of money. Now he wants to use those resources to build a new healthcare clinic just north of Toronto. And strangely enough, he doesn't want to make any money off it. The only problem, this might not quite be kosher. Let's figure out what's going on here. Joining us now from Marco Island, Florida, there's Walter Schroeder. It's good to see you again, Walter. How are you?
Very well, thank you, very well.
Excellent. Let's start from the beginning here. What kind of healthcare facility do you want to build?
I want to build what's called an ambulatory surgical center, which is a fancy name for same-day surgery. You do surgery, wait about 4 hours, you release the people. So you can do with that volume equal to probably about triple what a typical hospital can do, which is what our aim is to improve the efficiency of health and to help a lot of people get surgery that otherwise they wouldn't get.
What kind of surgical procedures are we talking about here?
We're talking probably a couple of types. It's got to be related somehow to pain. I'd like to alleviate pain with people, physical pain, and overcome the pain. So it's basically orthopedics, a lot of joints, knees, hips, shoulders, elbows, and done in a very, very high volume fashion, the same day release of the people. We can only hold the people 23 hours and 59 minutes, and they got to go. That's it.
Gotcha.
So it's going to be high volume.
Where do you want to build this clinic?
The building is 90% done. It's 15 miles from the Lake Ontario down Leslie Street. So Leslie plus 15 miles. It's 125,000 square feet, and it's virtually 90% done.
And what municipality is that in?
Richmond.
Richmond Hill. Okay.
Yep.
How much have you spent to build the place?
Well, it's going to cost us, put it this way, it went into bankruptcy, and they put 95 million in. And we found an opportunity to buy it for half that price. So we're putting half the money in to secure it. It's going to probably cost another close to 40 million to finish it. And then what we want to do is give it state-of-the-art equipment in orthopedics, and our second big venture is going to be imaging. So total cost over 100 million.
$100 million. And where is all that money going to come from?
Well, it's coming from our foundation. It's just coming basically from us personally. We've already committed over 80 million to Ontario Health. So this will be in addition to that. And will be designed to help people overcome pain and reduce the elective surgery list, which is skyrocketing in orthopedics.
So no money out of the public treasury for this? Not
We're
for the
looking
building
at
of the
doing,
place?
Well, the total thing is going to come to over 200 million. So we're asking we're employing 2 public hospitals. What the public hospitals will do, we'll be getting a loan probably somewhere in the 50 to 60 million range to help equip part of it, because the total bill will easily come to over 200 million. And we're maxing out at 150. So whatever the difference is, will have to come from public funds. But it's going to be triple us, and likely no more than 50 to 58 million from the public purse. That's it.
Okay, and do I have this right? You want to run this as a not-for-profit? You don't want to make any money off this?
We're not making any money off it. It's 100% charity. What we're trying to do is roughly about 40% St. Mike's Hospital is involved. Then another 35 to 40% of the square footage is going to go to another hospital. And we'll be in there with the clinic, but it's going to be 100% nonprofit. So this is not for profit, not 1 cent. We're not going to see 1 cent back from it. But we're going to help in the coordination between hospitals. Right now, Toronto hospitals really compete with each other. And we think we can partly change that by bringing a bunch of hospitals together to help with the surgery. And the surgery is going to be 100% of St. Mike's or this other hospital we're looking at. So we're not going to be doing that. But we're going to be providing the funding. We're going to bring the hospitals together, and we're going to coordinate a clinic with some surgery, with an attempt to reduce pain and reduce this terrific elective surgery backlog they have in Ontario right now today.
Oh, I know. The Financial Accountability Officer came out several months ago and said it's getting up there close to 500,000 procedures that are in the backlog right now. But again, I just want to hammer this home. The idea, if and when this is up and rolling, is that people would walk in, they'd put their OHIP card down, and all the services in there would be covered by the provincial health insurance plan. Yes?
it's going to be major of that. It's going to be mainly OHIP. We're going to have a clinic that's going to be doing things that are permitted right now. So the clinic part of it that we're going to be operating will be probably partially out of OHIP, if it is out of OHIP right now. But all that money is going to stay in the hospital, and it's going to be used either for equipment, or what our dream would be to subsidize free operations for people without OHIP at all. So the excess cash that we generate will either be used to subsidize free operations for people entirely, or will be used to buy modern equipment for the clinic, but nothing back to us, zero back to us.
Okay, I have an obvious question then, Walter. Why do you want to do this?
Well, we had a very successful life. Everything seemed to work out well for us in life, from university, from living in what today is the second and third poorest postal code in Canada. I grew up in the R3A, R3B postal code.
What city is
the
that?
Inner city, Winnipeg.
Winnipeg. And how did you make your money?
Made my money by taking a lot of chances and a lot of risk, creating a debt rating agency on the way to Montreal in the red Volkswagen with my wife taking notes and us getting there in 1975. And then a lot of hard work over the next 40 years. And we became number 4 in the world. Made a lot of money, sold it in 2015. And then I resolved to help people and help society with a good part of the money.
I think people have probably heard of it. Dominion Bond Rating Service was you, right? DBRS?
That's right. It's still number 4 in the world. And no longer, I don't have anything to do with it at all. We sold it 100%.
Okay, let me ask you a bit of an unusual question here, and that is what you're trying to do legal?
It is, because we're not doing anything outside of OHIP. Anything that's going to be done is going to be done by 2 hospitals. They're going to do the operations, and we're just going to provide really a couple of things. We're providing the real estate, which will go free to them. And secondly, we're providing much of the modern equipment, because donors today provide equipment for hospitals, basically. It doesn't come from the hospital, it comes from donors, and that's what we're doing. We're providing free real estate and free equipment, and the rest is up to OHIP, and it's going to totally stay within the hospital area. So,
all right, are all the I's dotted and are all the T's crossed, and is this a done deal?
It is from our part. We're going ahead with it, so let them close us down if they don't want to cooperate. But
well, what does the Ministry of Health have to say about it?
They're cooperating right now. They're looking at finalizing the funding.
Let me ask you this. You know there are people who are watching this right now who believe that it is inconsistent with Medicare to have anything privately owned, the likes of which you are doing, even if you want to run it as a not-for-profit. Could you speak to that concern of theirs, please?
Well, I think it's nonsense. I think right now, my expertise was credit ratings international. That was international countries. It was Canada. It was the provinces. It took Canada. It took the federal government 154 years to accumulate $800 billion in debt. Now, in 1 year, they're accumulating possibly $350 billion, and they're going to keep going at $100 billion a year. They haven't got enough money right now to keep doing the health system the way it is privately. You can see how it's collapsing. What we're doing is nothing for us, 100% for the people, and we're not asking for outside money outside of. St. Mike's is going to get some money to finish the operating rooms. And then what we're going to do is we're going to have 8 operating rooms that we're going to equip with 4 people you need for orthopedic surgery for an operating room. We'll equip them with that, and then allow qualified surgeons from all over Ontario to bring, say, 4 or 5 patients, which they can do in one operating session day. They can bring 5 patients down, do 4 and 5 hips, and the hospital is going to equip, at the hospital's cost, it's going to equip the operating rooms with the 4 people needed for surgery. The lead surgeon is going to bring his people with him that need orthopedic surgery, and they'll get it done in one day.
I'm
go
sure.
home the same day.
I'm sure our viewers are going to want to track your progress. What's this thing going to be called once it's up and going?
Well, we're calling it right now. We're going to call it right now the Richmond Hill Center. I'm not sure if I want to name it. We haven't decided that yet. We hope to have that thing done in 18 months is our aim.
Well,
But they tell me, the architects, it would take 70 years to do this from scratch. We're going to do it in hopefully 18 months. And our aim is to do 8,000 surgeries a year, which is equal to most of the Toronto hospitals in orthopedics. And we're also looking at a cancer unit. And then we're looking at the clinic that's going to look and give people health assessments looking forward. So looking at blood tests to tell if you've got cancer, they can identify 50 cancers with a blood test. If we can streamline it through from the blood test through to treatment and find cancer before it really gets going, then that's one of my objectives. And again, we're not making any money out of it. It's not private health at all. St. Mike's and this other hospital are going to be running all the show with anything to do with surgery. We're providing free real estate, we're providing brand new equipment, and we're providing coordination between hospitals to make sure the hospitals work together. So,
well, Walter Schroeder, we are grateful for your time tonight. Thanks for telling us how this is all going to work, and we'll continue to track your progress and maybe talk again down the road.
Thank you. We're going to get going on this too. We want this to happen.
And that is the agenda for Thursday, October 14th, 2021. Marie Hennen is one of Canada's top criminal defense lawyers. Tomorrow, Nan Kiwanuka talks to her about her riveting new memoir, Nothing But the Truth. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org. And Nam, we'll see you here tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.